Good morning, everyone. I'm Karthik Guja. I welcome you to the monthly endovascular live case webcast from Mount Sinai, New York. We have a cold morning here in New York. Um, Welcome again, and thank you all for joining us. Just a few key reminders before we go to the Mount Sinai Cath Lab, where Dr. Krishnan and Dr. Kapoor are waiting for us with an interesting case. The next live case is going to be on February 26th, Wednesday morning, as usual at 8 a.m. New York time. And another reminder is the previous live cases have been archived into www.ccc-livecases.org or peripheral-interventions.org. You guys can review it, and please do email us if you have any questions. Before going again, the annual Mount Sinai endovascular conference we have this year, we have some changes in the dates. Our annual fellows course, endovascular fellows course, is going to be on February 28th, which is a Tuesday, and sorry, April 28th, April 28th, I'm sorry, April 28th, which April 29th, and then the New York Endovascular Summit this year, the annual endovascular conference, which we have, is going to be on 30th and May 1st. Am I right, PK? 30th and May 1st. So we would love for you guys to go online, register for the conference. I think we have a very interesting conference coming this year, which is dedicated completely to peripheral endovascular cases, aortic and venous cases. And without any further delay, we'll move forward to the lab. PK, PK, good morning, Dr. Krishnan. Good morning, Dr.
Good mo-
Kapoor.
Good
Yeah.
morning, Karthik, and thanks so much for the nice introduction. And as you know, we're here in the cath lab with Vishal and myself, with our team, Haroon Cameron, our endovascular fellow, Ray Lascano, our endovascular NP, we got Elizabeth and Damien are here as well. We got a very interesting case, and Dr. Sardar Farhan is outside, going to show us some interesting pictures. But we've got a very interesting case for you today. But before that, just want to tell everybody what we've got planned. Karthik, myself, and Vishal. Our partnership with Link has been incredible. We had an incredible 3-year run with Link, and I thought the conference was phenomenal. But we've had to make some changes for multiple reasons, none of which are anything tragic. But we major reason we wanted to move the conference was to really move it into an area of the year which had more ability to attract all the different endovascular specialists, especially our surgical colleagues. Having the conference in June always meant that we had to compete with SVS, SVMB, so on and so forth. And so we thought we picked the week after or the last week in April and the first day in May, because we felt that that was an area which is kind of open for the conference, and we could really attract all the colleagues. The conference itself is no longer going to be held at Mount Sinai. The conference is going to be held at something called the ETC Center, which is a dedicated center in Midtown Manhattan, beautiful place. It's going to be divided into two large conference rooms in which we'll have the Endovascular Summit and the Aortic and Venous Summit. We've been very fortunate to have, along with the three of us, Dr. Luxstein, Dr. Rahul Patel, and Dr. Aklesh Sista of NYU to lead the venous side. And we've been very fortunate to have Dr. McKinsey, as well as Dr. Richard Ray, lead the aortic side. And of course, our very own Dr. Ferries will be overall director with myself and really running the conference. But the conference is going to continue on the same path that it always has, really showing exemplary live cases. We're hoping that our colleagues in Leipzig will send cases. We're waiting to hear from them, and in some preliminary discussions, and I hope that they will agree. I'm confident that they will, because Dirk has been an incredible supporter of our conference, as is Andre. So it would just add to the excitement to this conference. But along those lines, our fellows course, led by Vishal, Karthik, and Dr. Purushottam from North Dakota or South Dakota, has been a phenomenal success, and we'd like to go ahead and continue that on the 29th of April. The fellows course will again have cadaver labs. Will again have hands-on training as well as case-based education, and I think it'll be a phenomenal fellows course for everyone to come and attend. It's the first year of this new conference. We named it the New York Endovascular Summit, or NYEVS. Main reason is that we really truly want it to be an expression of all the different fields of endovascular and a demonstration. So the aortic, the venous, and the fellow. So it should be phenomenal. But along those lines, we have a very interesting case that we actually are presenting from our own lab. It's a case of ISR and with some of the challenges that we face with ISR, and I think it's a great illustration of how to deal with it. And I'm going to have Haroon go ahead and start us off with the case presentation.
Hi, good morning, everyone. Can you please go to the next slide?
What?
So our patient is a 67-year-old gentleman with a past medical history of hypertension, diabetes, dyslipidemia, and smoking, and a history of PAD.
What does that mean?
His status post-stent to the left SFA. He presents with left greater than right lifestyle-limiting claudication that has progressed to pain at rest, despite optimal medical therapy. Here are the medications listed. He had an ABI with exercise done as part of a non-invasive workup. On the left side, his ABI dropped from 0.92 to 0.67. A subsequent ultrasound revealed that he has a in-stent re-stenosis of the left SFA. He was then referred for an angiogram where it was confirmed that he has a left SFA ISR. An attempt to intervention at that time was unsuccessful, and he is now referred for further intervention. Next slide, please. So here are the angiograms from the prior attempt. As you can see on the low extremity runoff that he has an occluded stent in the SFA with a 3-vessel runoff. Here are the DSAs of the proximal stump and a distal reconstitution.
So Karthik, I think we're going to stop there. I want to show you what we tried earlier that we all failed. Show us the first picture. So you can see here one of the common mechanisms of failing, as you and I and Vishal know, is getting when you have this area of occluded vessel and then a stent that's it's sort of in the mid vessel, or you have a gap between two stents. I think it's a very common mode of failure where you get underneath the stent strut. And I think part of that, and I could talk to you and Vishal obviously was involved in this other case. So I think this can happen to any one of us, and really is just something where I think it was a real nice demonstration. I know we did an ISR last month by sticking the stent, and our plan here was to talk about how do you deal with the different modes of failure in ISR. Well, here you can see, Vishal, why don't you describe what you had done here, and then we'll talk a little bit about Karthik's approach and my approach.
Yeah, so in this case, the idea was again to try to cross over the stents and connect the two dots, but as you can see, you kept going on behind the stent. Initially, I started with an 035, but we went all the way in the back, created a dissection plane. Then I was trying to get back from the plane, like technically pierce the plane and try to get into the stent. And as you guys both know from the experience, it's very hard sometimes when you have so many stents. So I tried to see if I could downgrade to a stiffer wire like a Confianza and a Staro and try to puncture through the septum. But all the pictures you can see, it just kept going into different planes, and all my orthogonal views show failure. So my plan was to bring him back. I discussed with PK, and the idea was, okay, should we go? I mean, I'm sure you and PK are going to talk about other approaches, alternate modalities again, pedal axis, direct straight, retrograde, antegrade.
About it. Yeah. So at this stage, I mean, what anybody could have done is done the direct SFA stick. You saw that, we demonstrated it last time. You could have done that. You could have stuck the direct SFA, went up, externalized the wire.
Right.
You could have gone. The guy has. You'll see in the subsequent angiograms, he has. Your gentleman has 3-vessel runoff. So obviously you can actually get pedal access and come back up. Or you could show another technique, which is why we stopped the case there.
Right.
Because Vishal and I would have done the case on the spot, but we felt that it would be nice to show what are the other alternative mechanisms. But let's talk about the mechanism for this occurs. Karthik, I mean, when you see a stent between or a normal segment in between the stents or a normal segment, proximally to the stent, what's your and this could also happen distally to the stent, you know that. So what's the situation?
I think the problem comes when you have a segment proximal to the stent, right? Because if you have distal to the stent, it actually doesn't make much of a complicated case. But I think just this case, especially you have a proximal segment, there is some calcium which is going to deviate your wire from entering into the true lumen. Unless you are entering in the true lumen, you cannot get into the stent. Looks like Vishal went into the false lumen, which is very common, which is what would happen to 90% of the people who are trying to attempt this. So the question is what to do when you get into the false lumen and behind the stent, as you know. is basically try to loop up proximally if you can and get in. And most of the times we do this happens, and the question is what to do. This is all the case is all about. I think I would not say anything until we discuss some further options. But as we already discussed, direct stent SFA stick, and it depends on what kind of stent. That's the main problem. If it's a Supera stent, then direct SFA stick becomes a little difficult because of the closed cell structure. But this looks more like an open cell stent, so I think it's okay to stick this. Pedal access again is perfect for this. And the other option, I think you're going to talk about this. I'm not going to be a spoiler
No,
here.
it's okay. It's no big
Yeah,
deal.
I mean,
One of the things that we did was, I think Vishal chose the right catheter. He went with a directional catheter, and you can see what we did was we used the directional catheter, but what we did was we cut the catheter. I don't know whether you can see it. So we cut the catheter, and Sardar, run the loops of
the
fluorosaves
from today.
Scene minus it. So you can see the fluorosafe. So we did it just because we were waiting here, and we're like, you know what, let's just see what happens. And so what we did was we went with the catheter, and you can see here what I did was I just blindly pushed the catheter, and I tried to get out of the loop. So what you see here is just a blunt dissection with the catheter. And what we did with the catheter, if you can zoom in on us, is what we did was we took a regular JR4 catheter. Liz, can you hand me a JR4 catheter? What we did was we took a regular JR4 catheter and we basically cut it. Okay, and what you want to do is cut it in an angle. Okay, when you cut it in an angle, you create like a bevel. Can I have a JR4 catheter, guys? Somebody? A JR4 catheter, and so when you cut it in an angle, the angle will allow you to actually perforate the septum. So how do you cut it? So in this kind of situation, JR4, yeah. So what you want to do is you want to go ahead and cut it in an angle. And generally, what I do is I just take a scissor. And when you take a scissor.
Let's see if we can one second.
You're basically doing a several cut, right, PK?
You just want to do like a slash. It's kind of hard because the tip of the JR4 catheter is also soft. So what you want to do is you want to.
So we go to can we magnify on PK's hands?
Yeah, 1 second.
Dr. Krishnan's hands.
Okay.
It's going to be hard to see here, but I'm just going to cut it. See like that? You see that cut? I don't know if you guys can see it, and you see the bevel here. So you get like a bevel. I don't know. You can't really see it. So you can see the magnified motion on Serdar's screen.
Yeah.
You see I've got a bevel. You can even make it sharper than that. And what you do is you try to perforate the septum and get as close as possible. Once you get as close as possible, go to the next one, Sardar. You then go ahead with different wires. So we started with an 035 wire, and you see we're behind the stent struts. And just like Vishal did, you rotate to all different angles, and then you see, okay, so right here, you're off. It looks good there. You're off. Go to the next one, please. And then we added.
Next one.
We go to the next one, and then you'll see here we went with an Astado, and we were able to perforate through the septum, and we're able to get it. You can see here I'm pushing hard, and I think the Astado wire will come at some point. And then you'll see the Astado wire will just in your hands you can actually feel the wire perforate into the septum right there. See the difficulty in pushing, a little bit of rotation of the wire, and it pops right in. And then of course it takes a subintimal track. So that's where we are now. So now that we've crossed, we've got the subintimal track. And again, Karthik, you need to be careful not to go behind the stent struts.
That's right.
You need to go ahead and look at multiple different views to say that you're not. And then what you're going to do is rotate this catheter to see if it goes. It may not go. You may have to go with an 018 catheter, but that's okay. I mean, let's see. See, there's the rotation there. And then let's see if it pops in. And you also got to watch the stent, obviously. So the stent is not moving, right? I mean, if the stent starts to what is it called? What is that word I'm looking for? Deform or accordion or whatever you want to call it, right? So see it's not going there. So what I'm going to do is I'm going to ask for a Terumo Navicross here, which is a little bit stiffer and a little bit nicer than a JR catheter that's been modified.
So PK, I just want to tell you, I think this is a fantastic demonstration. Especially, this is very helpful. I mean, we have other devices like Entier or Crossboss or Stingray, which do the same thing. What we normally do in this plane, because this is a fine plane. You don't want to use like a anything like Outback or anything which is too aggressive for this plane. So this is great demonstration, because there are some countries where they don't have these expensive re-entry devices. This is like a poor man's method of re-entering into the stent. I think
Yeah.
it's great. I mean,
And also, Karthik, you could also use this below the knee. Ray and I have done it in the proximal tibials. We've done it in different areas where I mean, I don't think this is a good technique for distal tibial. I mean, although you could argue that with the new what is it called, angled quick cross, or the angled there you
the
go,
Supercross. Yeah.
angled supercross, you might be able to get in. So now you're in. Now we're going to pull this
Yeah.
wire out, and we're just going to go with an angled glide
angle.
wire, and then be able to get in. I mean, it's one of those things that, you know, I want it to be the option for our audience, because, you know, everybody's going to pedal, right? And
Yeah.
don't get me wrong. I mean, I believe in pedal. I think pedal has a role, but I think that, you know, you lose your skills if you constantly are bailing out to the pedal. And the whole point is, you know, this took us all of 3 minutes to do it. It's a little bit of, you know, thought process and thinking. And I think all you want to do is just say to yourself, hey, you know what? Let me try to do this. If it fails, then of course you've got to bail out of the pedal, right? So the Vishal's done a nice job getting a loop. Now you got to be careful,
Yeah.
because now you see you have the transition of the supera into this. So this is the next challenge. So here is when you want to take the catheter, and then you want to see whether you can just push it as a system here. Let's see how it goes. We'll see. This is definitely a challenge. And, you know, I always like to enter with a loop, but obviously this thing is not allowing us. Let's see whether we can enter with a loop here. You know, sometimes it's nasty.
There,
Yeah,
nice.
that's
But,
it.
you know, but the loop will definitely help us. Let's see whether this goes now. So now you're definitely through the supera. Now I'm gonna pull this wire out, which is really, really tight, and then try to see whether I can
You want to
progress
make the
this
loop
forward.
smaller, PK, a little
Yeah.
bit?
It's not. It's like a rock, Guja. It's a rock. I mean, I'm gonna have to go with. I'm worried to go with the straight wire in the supera. And supera ISR is really a pain in the you know what.
So PK, now that you know, it's hard, right? So we know this is definitely not like a stent thrombosis or anything. This is more like a chronic ISR, right? With a lot of fibrotic tissue in there. So but when you have the feel of the wire, do you change your strategy of how to do the further treatment for the patient?
You know what? That's a good question. But, you know, I'm a firm believer, like you see it's smooth here. I'm a firm
Always
believer that it's always combination, right? You
Right.
always have a little bit of thrombus. You always have a little bit of what is it called? The ISR tissue. And so what you have to do in these kind of cases is just go ahead and use a distal protection. The algorithm that the three of us created, I mean, clearly shows in ISR, you know, it's pretty much 100% embolism rate, no matter what device that you use. So you can see here, this is also important, because now you have to be careful how this loop enters this vessel. So you could also get subintimal here. Let's see whether we're lucky enough to just pop in, which I'm praying that we are, and we are. So we popped in.
Nice.
So now Ray's
Nice.
just gonna, or I'm just gonna push this forward. And now what we're gonna do is we're gonna get actually I want to go with the EV3 filter. So give us the spider filter, guys, because you're expecting a lot of embolization. Huh? Yeah, we're doing jet stream. So let's talk about how to treat now, Guja. Now, Vishal, obviously, what have you done on him in the past?
He came in, he had a stent place outside hospital, comes in, active smoker, still smoking, comes back with all the features that Kamran talked about. So he had a supera and a silver paste in, that's what they told me from an outside referring. So from my perspective, I initially tried to cross, and for reasons I had to stop because he was agitated, we had to lose a lot of dye and radiation. So we didn't do any definitive therapy, but his prior therapy was silver proximally and supera distally with DCB as well. So like I said, he's an active smoker. So there's almost like.
I mean, you know, silver is a great stent. 5-year data is phenomenal. Obviously, DCB with supera combination works very well in most patients. But, you know, when you have these type of recurrent re-stenosis, you know, the question is, what do you do? And I think the options are multiple, right? Well, you know, talk about your algorithm, Karthik, in terms of I mean, not in the OBL. Obviously, you're not going to do this in the OBL because sometimes it's very expensive. No, we need to put another wire down, and
So,
it's not going to fit through this.
I have as you said, the same algorithm as like normally all three of us do. It depends on the way we cross. If the wire crosses very smoothly, just for the audience, like PK had trouble getting this wire with a loop. That means there's a lot of ISR there. As PK said, there is always some amount of thrombus, chronic thrombus in the segments because there are islands of ISR, and between the two islands, there's always some amount of chronic thrombus left. Right. So when we cross, there is always a chance of embolization. So filter is like a necessity. I understand you can have 3-vessel runoff unless it's a very short segment of a stent. Some segments like this, long segment, in-stent re-stenosis needs a filter. If for this case, PK, I would not use an angiojet or anything because I think there's a lot of ISR in there. I would not hesitate to use a pathway here or a laser, actually, if so possible. Laser would not be a bad idea based on the trial. Eczema trial showed some good data. But pathway is not a bad idea to start here because...
Well, first of all, for our audience and for the company, Pathway was a great company that was purchased by Boston Scientific. So it's now the Jetstream.
It's Jetstream. That's true.
And you know what? Good job. I make the mistake all the time, and I always tell the Boston.
Yeah, I know. I keep forgetting because
our good friends, because it was such great marketing by that particular team. But the reality is, it is a Boston Scientific product and really working well. So what are some of the advantages of the Jetstream for you, Vishal?
Okay, Vishal, go ahead.
No, go ahead, Karthik. That's fine. I mean, it's just mainly an aspiration. It's an atherectomy and an aspiration device. So it comes in like two forms. Like it has the advantages. It has a low-grade blade, and you can upsize it. So it comes in two formats: 2030 and a 2434. So what happens is, it's like you have blades down and blades up. So it uses an atherectomy. And once you do your runs on the lower blade, you can actually increase the size and go up to a higher blade to
Vishal,
get better.
I see you guys are using a Jetstream there. I see that.
Correct.
So what kind of what's the size of the Jetstream you guys are using, Vishal?
2434. So it's 2.4 millimeter, 3.4 millimeter with blades up and down respectively.
So what we're gonna do, Karthik, is like we've got the spider filter down, right? We're gonna run the Jetstream once, probably blades up or blades down. We'll figure it out. But remember that embolization is going to be a major issue with anything. I mean, I don't want anybody to think that that the Jetstream embolize. Oh, we got to test it.
Mm-hmm. I think they tested already.
Oh, you did.
Yeah.
So the Jetstream embolizes or not? I really don't believe that's the case.
Hold on 1 second. Let me walk
I really believe that. Obviously, don't pull the filter. I really believe that. This is a 7 French sheet, guys.
Yes.
Oh, okay, there it goes.
So
it's important to go with the 7 French sheath, obviously. Second thing, it's also very important to understand that the Jetstream is going to be tight going up and over the arch, which is normal, right? Then you want to engage, and then he's going to go ahead and do it. And then what we're going to do is we're going to just do short runs. And Liz, he may have some pain.
So PK, just a small question. So this is we know there is a dissection plane proximally, right?
Right.
So why there is a reason why you choose Jetstream here, right? Because Jetstream has a differential cutting.
Yes.
Right? Am I right? So I think that's very important point for everybody to know that Jetstream has differential cutting, which cuts only in areas where there's a differential contact, which avoids any kind of dissection plane cut. It usually takes into more into the ISR or the intimal hyperplasia area, right, PK?
Yeah, I think that point is very important. I mean, I remember that our good friends at the old company would just go ahead and put the Jetstream on his tongue in just to show you that it won't cut his tongue.
Right.
So I mean, it's pretty interesting to see this, and the whole idea is to run it slow, run it through, and then create a lumen. The nice thing about the Jetstream is you're not only getting atheroablation, you're also getting aspiration. So as you can see, you will see some blood come out of this as we start getting into the tissue, but it is aspirating acutely as we go through. So I'm just going to run this down slowly, and
but when PK is doing it, I just want to explain to the viewers. So Jetstream comes in blades down and blades up. If we can magnify a little bit, PK, we can show them blades down and blades up.
Yeah,
absolutely.
The device has like wings, which kind of have their blades down. So we run one run with blades down, which has which gives you a cut. If it's a 2.4 to 3.0, it gives a lumen of about 3.5 to 4.0 with blades down. And if you have a blades up, then it takes about 1 millimeter high amount of differential cutting. So you get like about 4 to 5 kind of a lumen, which is great because the device becomes like a 3.5 device. Right, PK? Am I right?
Absolutely. So right now, you know, he had some pain. So that was the area of maximum dissection that we had. So now we're going through the stent, right? And I think part of that is to understand that you have a lot of, you know, you may have pain, you may have other things. So, you know, be sensitive in those dissection planes, and then you're just gonna go through making a channel. It's a very fibrotic lesion, you know, as you can see by the grinding, you know, very, very fibrotic. You can see the blades down rolling off.
Yep.
Off.
Right in the middle of the bullet.
Every now and then you want to go ahead and check your filter. Make sure your filter hasn't moved. And again, your filter has moved. So I'm just going to go ahead and pull the filter back by pressing the button and just pulling the filter back a little bit right there, which is going to occur.
A reason to use a spider.
I know, I was going to ask him.
Well, you know, to me, we use a lot of Ember Shield. And to the fact, I wanted to demonstrate that the spider filter can also be used. In our study, we obviously, with the Ember Shield approval for atherectomy in SFA lesions, we showed that with the jet stream, the Ember Shield is safe. And some complaints with the Ember Shield had been that the Ember Shield filter would migrate proximal towards the filter. We did not see that in our patients that we studied in our study. So therefore, the Ember Shield has FDA approval with this. I'm just using the spider because, hey, look, the spider moved downstream. You know what I mean? So everything is going to move. So you have to have an idea that you have to check on that filter every now and then to see what's happening. Perfect. So here we're going to go back on. And we're just going to try to come through. You also notice I went up and checked my...
you can probably catch the wire, I think, once, you know.
No, I mean, the wire is looped like a rota wire. Yeah. So, you know, technically it should not move, and that's the whole idea. Yeah. So, it's okay. It still is...
I mean, look, in ideal case, yeah, it's not going to move, but everything moves. You know? And, you know, here's the atheroablation that's occurring.
So I think the blades are very visible here when we go up. Yeah.
Yes.
So I'm just going to do the blades down just to create. Now this is going to be an interesting thing for me, you know, where I don't want to be.
Any other atherectomy device you would choose if somebody doesn't have a jet stream available?
I think obviously you can do laser. I think you can do a balloon angioplasty or cutting balloon or atherotomy balloon, which is what we're going to use here after this to really expand this. You know, you always got to be cognizant of embolization, which is what I keep looking at my filter, because right now I really don't have much of a channel, and you can see my filter keeps on moving. So this is definitely an issue.
So what about directional PK?
Directional atherectomy is contraindicated, but as you know, Vishal, we do it a lot. And, you know, so we're just going to run this down on. So I think all those things... Whatever.
Oh, no, with the blade, the wire.
Oh, the wire came off. Sorry, that was my mistake. So on.
So that's a great thing, PK, because see, we have all the toys in the world because it's Mount Sinai. We have all cool toys available for us, so we can use different devices. But there are some hospitals who have only one kind of device. I think it's important for audience to know that, as Vishal was just pointed out, you know, if you have you don't have you cannot use directional atherectomy devices in in-stent. They are contraindicated, or they are not indicated. They are not FDA approved. So because they can get stuck in the metal struts. That's a very important point, PK, Vishal, that you brought up.
And so is CSI as well.
CSI as well. So that's which are the two most common devices used all over the United States.
Right.
So what probably most of the people have available in their hands. I think laser and Jetstream are the two good devices to use if there's a lot of in-stent available. PK, you have Philips has a Phoenix device. You think Phoenix device is good in using in in-stent?
I mean, Karthik, I think you have a lot of experience with that, more than me and Vishal. So I don't know what your thoughts are.
I mean, I feel like it works just like Jetstream because it has both atherectomy as well as aspiration capabilities, but it doesn't create as, I mean, you can use this, now they have come up with a 7 French system, but I think, I would definitely go with Jetstream first because it would be a preferable thing to do.
Well, Jetstream has data off. So you know what? Jetstream has data. So I'm going to stop here because I don't want to go all the way down and do this. What I'm going to do is I'm going to run the penumbra and aspirate the lumen now.
Right.
And I'm not going to use a regular penumbra. I'm going to use actually give me a penumbra and we'll aspirate the lumen. And what I'm going to do is I'm going to have Vishal walk this out. And this is a trick that I've learned over the years in that, so you want to Rex on the way out.
Exactly.
So I'm Rexing as Vishal comes out. Watch the filter, pull the filter, yep. So as Vishal comes out, I'm Rexing, which is going to help us bring it up and over. I'm fixing my sheet, so this way the sheet doesn't track back. So I'm just putting positive on my sheet. And Vishal's you're going to see it decelerate as he comes over the arch. And then what I'm going to do is I'm going to run the penumbra because I've created all this debris. And before I create a communication, yep, that's normal. He's going to pull now, and it's going to come out. Just pull.
And I want to watch my filter.
So this one, there you go, beautiful. So this is expected, right?
So PK, one question. I'm sure a lot of viewers will have this question because it's running in my mind. So I'm pretty sure a lot of people will have it in their mind is, if you're not doing any kind of, if somebody decides not to use an atherectomy device, right, and wants to just balloon it with, with a cutting balloon or, scoring balloon, and then use a DCB straight up, you still need a filter. Would you still use a filter, Vishal?
I generally, we use filter with atherectomy, but I don't want people to get to, you need to understand how the wire crosses. And I think that's very, very important, how the wire crosses. If the wire crosses like butter, that's a different story. Then obviously it's something that you need to watch out for. Then it's all thrombus. If the wire crosses slowly, and then that, like the way we did struggling to get through, then it's a lot of fibrous tissue, and it's a different story. So I'm just going to go ahead with this. I know it's going to bleed back a little. Vishal's just going to hold the filter.
Vishal, would you use a filter if you're just scoring or cutting and then using a DCB, or?
Well, if it depends.
If you're using a covered stent or another silver, I don't know what the plan is going to be, but what would you use?
It all depends. If, like PK said, if you expect a lot of thrombotic component, then I would probably use a filter. But if it's more fibrotic and a 3-vessel runoff, and we're not doing any atherectomy, so the chances of distal embolization are less, so I might wave away from it. In these cases, like you always say, there's definitely a component of thrombus and fibrosis, intimal hyperplasia. So to be on a safer side, I'll use a filter because then we're chasing our own tail, and then it just prolongs the whole misery. So
absolutely.
Right.
So PK, what are we doing here?
So right now, so my idea was not to create a full through and through communication distally because of all the long runs we did with the Jetstream. What's going to happen is you're going to have a lot of debris within the stent itself. So my idea now is to aspirate the stent. Of course, for some reason we don't have what we need here and we're waiting. But the idea would be to have things set up and plan these procedures out. So now Damien, being Damien, is able to get it very quickly, and we're going to go ahead and attach and aspirate this. Now, this is an expensive device, I realize that, but there is thrombotic component to it. The second thing is that you have to also understand that the issue here is going to be, the embolization will be catastrophic if it does occur. So what we're going to do is we're just going to attach it. He's going to turn it on.
It's on whenever you're ready.
Okay, so nothing is coming out.
No, I'm going to turn it on.
Turn it on. So now we're just going to get the aspiration going. And as the aspiration, I'm even asking Vishal to walk it back a little bit.
Just for the viewers, I just want to tell you what PK is using is a penumbra device. A penumbra device it was initially approved for a cerebral aspiration, as a cerebral aspiration catheter in strokes, in acute strokes and everything. But has been now PK, is it approved for peripherals or?
I don't know whether it has an actual approval for peripheral, Karthik. I do know that it works really, really well.
Yeah. Okay. Because PK has a maximum experience out of everybody, so.
Well, no, actually, a lot of people are using it. Honestly, I do a lot of it, as you know. We both do a lot of it. But again, this is common that sometimes it won't go through. But it's trickling back and forth. So even if we can aspirate a little bit, it's going to help. But it's not. So we're going to walk it back now. And now what I'm going to do is I'm going to go with a balloon. Give me a long 01460 balloon, guys.
So PK, that's a great way of doing it. I think a lot of people would just go through and through the stent and then atherectomize the whole thing, but and then everything, all the debris is going to go down and
Look at the
catch on the filter.
I don't like my
This is a
filter.
great way of doing it. You did it until the end of the end of the stent, and then you stopped. So a lot of debris is going to be within the stent,
Right.
and then it's easy to suck it within the stent and then balloon it. So
Well,
less debris is going to go to the filter.
Again, I totally agree with you, but I think again it's an expensive way to do it. You know, and the expense is an issue. You know, it's very expensive. So we're going to take a picture now and check the filter. You know, the filter came back a little bit. So you know, we're just going to go back, push the filter down. Obviously, more movement of the filter is an issue. Ready to inject? I don't think there should be any flow through the filter at this stage because we haven't come all the way through the stent. We'll see. Sometimes you're surprised because you cross with the catheter and,
With the
and there it is.
catheter.
Yeah. So the filter's still empty, right? Which is good. So
good.
now we're going to go with a balloon and then we're going to aspirate again. Now is the time where you have to be incredibly careful with the filter. So let's
What
talk
kind of balloon are we using, PK?
I'm using an 014 Abbott balloon. It's a 60250, right? 60200 balloon. And now let's talk about some definitive therapy. I mean, you've already used Zilver. You've already used what is it called? What is it called? No, DCB.
Yeah.
You've already used Supera. What's the story, Karthik? What would you do?
For this patient, I think, I mean, for this patient, definitely they have used everything. But, you know, I think this is in-stent, and this is a Zilver in-stent. It's not like DCB is going to do some magic here because it's a drug-coated stent. It's a drug-eluting stent which was used here. So, and there is not major, it's a 3-vessel runoff, especially if you're talking about this patient, and there is not major collaterals coming off and through. For this patient, actually using a covered stent would not be a bad idea at all, PK. I would actually go with a covered stent.
Right, Lomag. So a covered stent's a good idea. Say they don't have covered stents in certain areas, what would you do then?
I would definitely go with the DCB. I would use a balloon, a non-compliant balloon as much as possible, create the maximum lumen, and probably use a DCB and reline it with the DCB. So, and give it another option and a choice. But the problem is we have created a dissection plane proximal to the stent. So I would definitely stent the proximal area. To get a better lumen, and then DCB rest of the in-stent re-stenosis. That would be my option of doing it. I would definitely not just leave it with the plain PTA.
Oh, definitely not. I agree with that. I think
That's
we all
like
agree with that.
that's obsolete. So
you can see Vishal is expanding it. You also want to watch how this thing expands nicely.
Yeah.
So
I mean, we can argue about using another Zilver, but using a Zilver, another drug-eluting stent in a drug-eluting stent, I don't know how much that option is going to work out.
Well, you know, there is data with Zilver. Obviously, you know, in ISR, there's data with DCB in ISR. There's data with a lot of stuff in ISR. So it's not like we're without data. But I mean, the only randomized control trial is the Excite down, which we know that Excite clearly didn't excite us a lot. So I think that you know, in 6 months it's definitely better than PTA. But I mean, I think we're looking for a little bit better outcome. Haroon, have you prepared anything for us?
Yes.
Okay, let's go to the slide set with Haroon while we're ballooning this. Walk it back to this. Don't move the filter.
Okay, go to the next slide,
Wait,
please.
it's not down yet. It's not down.
Let me. It's hard to see. So let me just go through the.
You're out. There you are.
Slide presentations. Go to the next slide.
That's the double dot.
Look, let me go forward.
Next slide. Next. Next.
Okay, go
right there.
Okay. So let me just walk you through this filter algorithm. This was proposed and published by our group at Sinai based on a study of 508 patients with symptomatic PAD that were treated with atherectomy and filter device in a single center between 2014 and 2015. The lesion morphology for this study was classified as either atherosclerotic, calcific, ISR, thrombotic based on angiography and later confirmed on histology. Macroembolization was identified in 62.4% of the patients. On a multivariate logistic regression analysis, the high-risk lesions likely to benefit from distal embolization protection during atherectomy included CTO of the ISR, CTO, ISR, thrombotic, calcific lesions that are more than 40 millimeters and atherosclerotic lesions greater than 140 millimeters and less than 2-vessel runoff. Next slide, please.
That's one.
Okay.
I'm going to get off the roadmap.
Can we minimize it a little better. Okay, so this is the FAIR trial. So this is a prospective multi-center randomized trial at 5 centers in Germany.
Beautiful.
119 patients with SFA, ISR, and CLI were recruited. Mean lesion length was 82.2 millimeters. Lesion morphology was noted to be 29% CTO and 25% heavily calcific. Recurrent ISR was 15% versus 45% favor of DCB. Freedom from TLR was 91% versus 53% also in favor of DCB. And improvement greater than 1 Rutherford category was 78% versus 52% in favor of DCB versus the PTA. Next slide, please. So next trial is the PECUBA trial. This was published in JACC Interventions. This was also a study comparing DCB. Go to the previous format, please.
Disease,
Yeah, that's fine. Thank you. So this was a comparison between DCB versus PTA. This was a prospective multi-center randomized trial. Go to the next slide, please. Sorry. This is the PECUBA trial. This is a prospective randomized single-blind dual-center study.
Beautiful.
A total of 74 patients with SFA, popliteal ISR were 1-to-1 randomized either to a PTA or a DCB. Mean lesion length was 17.3 centimeters versus 18.4 centimeters. The primary patency rate was 40.7% versus 13.4% in favor of the DCB.
The inflow that killed it.
Freedom from clinically driven TLR was 49% versus 22.1% and also in favor of DCB. An improvement by greater than 1 Rutherford category was 68.8% versus 54% at 1 year, also in favor of DCB. Next slide, please. Next is the debate ISR study. This was also a comparison between DCB versus PTA. This was a prospective single-center all-comer study. Symptomatic diabetic patients with FEMPOP ISR with CLI was recruited. Mean lesion length was 132 millimeters. Recurrent re-stenosis was 19.5% for the DCB arm and 71% for a PTA group. TLR was 13.6% for the DCB arm and 31% for the PTA arm. Interestingly, at 3 years, the TLR between DCB and PTA remains similar at 40% versus 43%, suggesting a late catch-up phenomena. Next slide, please. So this is the IMPACT Global study. This was also published in JACC Interventions. This was a drug-coated balloon feasibility study. This was an independently adjudicated multi-center prospective single-arm study. 131 subjects with 149 ISR lesions were recruited. Mean lesion length was 17.17. Lesion morphology was 34% CTO and 59% calcific. Clinically driven TLR was at 12 months 7.38% for DCB. Primary patency at 12 months was 88%. Freedom from clinically driven TLR was 92.9% at 12 months. Next slide, please. So this is the RELINE study based on a Viaban endoprosthesis. This was a prospective randomized control study. 39 patients with Viaban versus 44 patients with PTA were compared. Mean lesion length was 173 versus 190 millimeters. Primary patency was 75% in favor of Viaban. Freedom from clinically driven TLR was 79.9%, also in favor of Viaban, and improvement by greater than 1 Rutherford category was 97% versus 81% at 6 months. Next slide, please. So this is the Zilver PTX study for a drug-eluting stent for FEMPOP ISR. This is a single-arm prospective multicenter clinical study. Mean lesion length was 133. Primary patency at 6 months was 95.7% and 78.8% at 1 year. Freedom from TLR was 96% 6 months, 81% 1 year, and 61% at 2 years. Risk of stent fracture, interestingly, for this study was 1.2%. Next slide. And this is the laser atherectomy study comparing laser versus PTA. This was the EXCITE ISR trial, also published in JACC Interventions. This was a multi-center prospective randomized control trial. Patients are randomly assigned to laser plus PTA versus PTA alone. The mean lesion length for this trial was 19.6 versus 19.3. Freedom for TLR was 73.5% in favor of laser plus PTA. 30-day adverse event rate was also lower for the laser plus PTA at 5.8%, and a 52% reduction was noted in the laser plus PTA arm. Next slide, please. So in summary, the endovascular treatment of FEMPOP ISR has increased and will continue to grow. Although repeat FEMPOP ISR and the need for additional intervention remains all too common, little consensus exists regarding the best treatment algorithm. The use of DCB could be recommended as the first choice or device to treat FEMPOP ISR because of its efficacy and ease of use. In complex lesions such as in-stent total occlusion, critical limb ischemia with diabetes, VABN, or drug-eluting stent, implantation might be a more suitable option. Thank you.
So excellent overview, Haroon. Great job.
Okay.
Good job. I mean, if you look at what we're dealing with, and Vishal and I were kind of talking offline. So this is the DSA post balloon angioplasty. Remember, we didn't touch this area. So you've got a diffusely diseased area with I guess there's a dissection there, which I did not touch. I don't know where that's from, but again, it's non-flow limiting. Then we have an area here. The stent and the supera look okay. A little bit of ISR in the supera, and then but if you look at the proximal, the stent looks very good. Really, just kind of good flow within the stent, the old Zilver, as well as the supera proximally, and then proximally you have this. So obviously the choices are Vibon. We could re-Zilver. We could impact. We could also use a newer stent design and use a Alluvia. But first, I think the question that Vishal and I discussed, which we'll ask you, is would you reline the entire segment, knowing that there's that distal disease, or how would you do it with a Viabon?
Yeah, I think, Reline study is very clear, right? The average, they have 190, right, as a length PK. So we are talking about 250 here. So, and it's a 3-vessel runoff. So I would reline the whole thing. If I have to reline it with the Viabon, I would reline the whole thing and give a completely new segment for the patient. And it's 3-vessel runoff, so I think the patency is going to be great. So, but if you're not planning to reline,
no, but what about the distal disease? The mechanism of failure is.
I would cover that, right? So looks like,
but you're going to lose those collaterals, right? And I
so,
think
but I think the major profunda collateral is much distal. That's where the filter tip is, right? So I don't think any of the collaterals come in there. They're just small branches. They look like they're more intramuscular branches right there. That's it.
No, I think that's the major profunda collateral.
Yeah, because no, I think your profunda collateral comes distally, right?
No, I'll show you. I'll show you the pre-shot. So when you go to the pre-shot, and I think that's the worry about losing the collateral, because shit. Pardon my language.
Keep going forward.
Hold on a second here. There we go.
I think PK is right. It's all about the mechanism of failure.
If you look at it right there, see the stent is right there, and the profunda collateral is
right there.
See, the major collateral comes much distally. See that? So technically you can line it. That's why I was saying probably Viabon is a good option.
Yeah.
Because you can go right to that first collateral and line from there, because your dissection is just distal to the stent. So you don't have to come distally. You just can go proximal to that first major collateral, and I think you'll get a great result. That's what I would do. But if we decide on not doing it, then we have to stent distally and proximally, and then DCB the rest of the stuff, right? You can neither leave the proximal segment nor the distal segment alone.
Yeah, that's nice.
I kind of agree with you. I think you're changing my mind. I think give me a 60250 Viabon now.
So Karthik, how about I put a twister to this? So the mechanism of action you think in this case is more of the proximal disease worsening and then causing the ISR, or is the other way around, or we don't know?
No, I think it's the proximal disease worsening and causing the ISR.
Then why not do a supera or a Zilver there? Distal, if you're concerned about covering, and then do the Viabon for the rest of the ISR segment.
So Vishal, the question is, what are you achieving by doing multiple stent segments, right? It's a 3-vessel run. It's a 3-vessel runoff.
To me, I think one of the things that I agree with Vishal is, the mechanism of failure is probably the proximal segment. So but I'm worried about putting a Viabon because of the distal segment. Same time, I'm also okay with what you're saying. If I can avoid that collateral and land the Viabon just proximal to it, I'm okay with it. So what I'm going to do here is I'm going to go with the Viabon to that level, and then let's deploy it, and then let's see how the proximal looks.
So PK, doing a devil's advocate, right? I mean, uh, actually, bypass. She's a claudican, but bypass is actually a great option for a 3-vessel runoff patient, right? Because the landing segment, the pop segment is great, but because she's a claudican, I think it's worth giving her a shot with because this is the first time she's re-stenosing, and it's a DES re-stenosis. It's worth giving a shot with either a DCB or a covered stent.
I agree
just putting another bare metal stent, I don't think is the right option for this patient.
There's no question. I don't think I would put a bare metal stent. Neither would Vishal. The only idea was because the silver looks so good after we ballooned it, is to use a different metal or a different stent proximally like the Alluvia, which I still may do, and just go ahead and cover and just DCB the rest. But I was a little, what's the wire? I was a little hesitant of covering. That's okay. You can leave it right there. Of covering the entire stent because of that distal segment. Now I feel a lot better because of the fact that we got the major collateral distal. If we can avoid that distal collateral, I think we're going to be fine. And I think this is going to be kind of where I'm going to land it right there.
That's perfect.
So I'm going to let Vishal go ahead and deploy it. Very simple. Vishal, can you walk through it?
All right, so it's like a self-expanding stent. It has a long wire. So you unscrew it. There's no balloon or anything. And there's no pin and pull. Yeah,
right.
That's what I'm thinking.
Watch it. It went forward, Vishal. Can you pull back?
PK was pushing
it.
I
think that's okay right there.
So you just unscrew it, and the thread would come out, and you keep pulling the thread back. You will not see any change initially, but when the thread is almost 3/4 there, you'll start to see the stent struts open up right there. So I'm going to go slow. Till then, we have my first segment of my stent open up.
I think right now you should see it.
Yeah, now you're going to see
that's it.
It's a little distal.
That's it. Yep. No, it's good. It's good.
That's
perfect.
Good. Perfect.
Yep, that's actually perfect.
And
yeah, it's perfect.
Okay, now we're just going to walk it out off-road map, right?
Yeah.
I'm sorry. Actually,
it's perfect.
It's okay. It's right there. Just above it.
There's the proximal marker.
Yeah.
Okay. Now we're going to go ahead and decide what we're going to do here from here to here. Do we put another vibe on, or do we just silver, or we just Alluvia? I think we'll Alluvia the prox here.
Yeah.
With the drug. Okay. What length do you need here? Let's see. Roadmap.
Roadmap it is.
You need at least 150, right?
We have a 6.0 and a 7.0 140, I think.
140 is plenty. 6.0 140. You're not out yet. You got a little bit more.
That's what I thought.
Alluvia.
What? 6.0.
120 is fine.
So you're going to leave a segment of the prior stent in between, PK?
I mean, the idea is, so the options are, you going to put another Viabon all the way up to the ostium, or are you going to go ahead and just do a drug-coated stent in the ostium? Because I personally think this failed because of the ostium and the distal. That's what I think.
Right.
Because the stent is too clean for me.
Right.
So what I'm going to do now is I'm just going to go ahead and use the 6.0 stent, 6.0 Alluvia. I think you could probably use a silver if you wanted. But the fact that it failed with a silver...
PK, you're using a 6.0? You didn't want to go with a 7.0?
120?
You can go with a 7.0. You have a 7.0 130, guys? No. So we'll go with a 6.0. I think it's a 6.0 vessel. So we'll go with a 6.0 130, and then we'll do it. Call Serdar. So 6.0 130, and or 120. So what we're going to do is, Damien, I need a 014 7.0 balloon now. 7.0 long.
You flash it.
The 7.0 you're using is for the Viabon, PK, right?
Yeah.
I'm going to balloon the whole segment with a 7.
Okay. Even the 6.0 stent, you're going to go with a 7.0 balloon?
Yeah, I don't think it matters at this stage. I mean, we're just going to expand it nicely and leave it alone.
Okay.
Straighten it. I want to come out. There. Okay, you walk in. Perfect. Go.
Okay.
Walk.
Don't touch the pathway or the jet stream. Okay.
Good.
So now we're just going to go in. Rail. Nice rail.
The rail.
Yeah.
So PK, by the time you're putting the stent, I think a good point which you raised for the pedal axis. I think, would you use a pedal axis for an in-stent, PK?
I mean, you could. I mean, the whole idea here is so here you see. Now, if you want, let's talk a little bit. We're a little bit long. I think we're going to cover a lot of it, which is fine.
Yeah,
but now I'm in a 7.0
I
sheath.
guess.
So I think what we want to do here is one of the techniques that you can do if you have a larger sheath to hit the ostium is not worry about the distal.
Yes.
And then what I can do is I can just give a little puff. No, you go ahead. You want to deploy it, buddy? You want to deploy it?
Yeah, sure.
Yeah. So do you want me to do it on roadmap it, or how do you want to do it?
Yeah.
How are you comfortable? Let's roadmap it. Okay, and then we'll start it, and then we'll check it.
Yeah.
So we'll roadmap it here. So I like that. I maybe come back slightly, Vishal.
Yeah, slightly a little
Slightly
bit.
straighten this. Keep the
Slightly a
system
little
straight. Straight.
Right there.
Okay. Oh, you came back a little too much. Let's go forward a little bit.
I think that's good.
Right there.
Perfect.
Right. Now you know
it's a huge
it's gonna
disease-free
jump forward.
profunda, so it's okay, I guess.
It's gonna jump forward a
You
little
have a
bit.
forward tension
Yeah.
a little bit.
Yeah, you take care of it. You can do everything, right? No, I wouldn't worry about that.
Okay.
I would
just wanna make
adjust
sure.
it from here.
Yeah.
Yeah, I would just like, yep.
Just
as
pull
it-
it. Yeah, that's good. That's good. It's a huge profunda, and there is a nice play there. So, and it's a
You're
it's
gonna
a
push
very
forward
favorable angle. So,
You want to push forward?
Yeah. It's going to pop back.
How's that? More?
That should be good. It's going to flare up. It's an angulation.
Mm-hmm.
Real forward tension on it.
Forward tension. I shouldn't hold this though. That's the problem. Because remember, part of the deployment of this is going to be where you don't want to hold this, and the whole idea is the system should be straight.
Yeah, it's a triaxial system.
So you
shouldn't
got to
move.
keep the system straight without pulling. Now it's a little too late, but I think you're still beautiful. You know, it's just gonna now let it go forward if it will.
Yeah.
You know,
I'm
if
not
it
putting it
doesn't,
on.
no
Have a
problem. I'm gonna
slack.
put a little bit forward tension here for you. Right, like right
so
there.
Vishal, PK always told me when I was in training, he said the best deployment of osteal SF stent is one stent strut, one cell into the
Right.
profunda. So
I don't understand.
that's when you know you covered the ostium. He used to tell me. So I
Well,
don't
you
know if
have
the-
to, but you know, the point is, you know, if you can avoid it, that's great. But here, Vishal is doing a great job of just being little negative tension, right? Right, perfect. Letting it go forward and backward, and then you can see here how nicely the Alluvia stent deploys without even on a dime, really, just sort of on a dime. Look at that, beautiful, perfect.
Perfect.
So you
That's
nailed
good.
it perfectly. So now let's off-road map. Okay. Let's go down and look at our filter again. Oh, filter is all the way back now. So part of that worry is you have to worry about this. So
Getting catch.
let's go ahead and just push it forward. It's inside the
covered
That's what I
stent.
had. See,
He's not coming? What's happening?
now I just hold on. Wait for.
So I think
What
at
is
this
that?
point you
I
can
don't know,
just
it just came up.
retrieve the filter, right, PK?
Yeah, I think I would.
Yeah,
just
but you have to be
retrieve it.
careful about toothpasting, Karthik. You know, and I think that's another thing I want to talk about with covered stent systems. When you can toothpaste the on balloon angioplasty, so I like to leave the filter down, and I'm just going to push it down because you know, I know this filter is empty, but it's obviously not ideal. But
Yeah.
you know, I'm just going to go with the 7.0 Armada now, and I'm going to leave this filter down right there. And I'm going to, you know, I still worry about toothpasting. Hopefully the Armada goes through. It may not. If not, give me a 60250 balloon again.
So for the viewers, what PK is concerned about is if there is thrombus
60200 is fine.
behind the covered stent and between the stent struts and the covered stent, when you balloon the covered stent, you can spill a lot of the thrombus out of the stent down into the downstream, right, PK? That's exactly what you're
Yeah,
concerned with.
that's the whole idea of toothpasting, and you have to be a little careful on that and cognizant of it. It
Watch
can
your
still
face.
occur, you know, and it's not ideal that the filter moved, but we know the filter was empty, which we're lucky. But I mean, you know, listen, these things happen, and you just have to be cognizant of these things happening. I mean, it's one of those things that we do a lot of cases, and filters move for everyone, and you know, a lot of people don't like to use filters for that reason. But
We're using a non-compliant balloon here, PK?
yeah, because I'm going with a 6.0 because it's an 014 system. I'm just going to go ahead, rail, please. I'm just going to go ahead and get to this distal area and balloon this. And
Do you want to see the balloon coming into the alluvia,
It should be okay because that's why I went really with an 014 system. And I think the 014. Let's go up right here. I don't want to come outside this stent if I don't have to. And I'm just going to go up. Let me just check my filter where it is.
I'm sure Karthik is happy sitting on the other side, not taking care of the filter.
Sorry. Right here. Go up now. So.
I mean, the filter is moving because of PK, Vishal. So.
Oh my goodness.
Yeah. That barrel has never been won, Karthik. It will never be won.
Slow down a little bit. Yeah, right there. That's good.
I'm still 4.
That's
4, 6, 8, 10.
It's a nice expansion. Down.
10. Okay, good. So now we're just looking at the expansion of the stent. And what I'm going to do is I'm going to pull back. I'm going to pull back and go high pressure now, down.
Reduce the magnification.
And then pull back to like 5 and then go really, really high pressure.
Yeah.
Now remember, it's important inside the supera to go ahead with really high pressure because that supera wasn't fully expanded. Right here, let's go up high pressure. Really high pressure here. And we're going to go to like 20, 25 here. If we can, with this balloon, just to really try to expand our non-compliant balloon. So you can see here, see now how nicely that's expanding. And again, go. What are you up to now?
22.
22,
and
this
that's
is
pretty
now,
good.
Right, 22, 24.
Okay. I mean,
down. Good.
Vishal, you still have to worry about that non-stented segment, so be careful.
Yeah.
Yeah, and then we can go here and do the proximal. Just let's see, you're right there. Go, pull it back now.
And this is a 6 stent, Vishal, just so that.
Yeah, I'm gonna go slow. Yep.
A little bit further back.
Probably like nominal should be enough.
Just to make sure I cover the.
No, you got plenty.
Okay. Oh yeah, that's true.
You got plenty. Come back. It's a 200 balloon.
Yeah.
Yeah, you can come back to the ostium, Vishal.
Right there. Stop there.
That's good.
So this balloon tends to. It's not like a corner balloon. It tends to expand.
Yeah. Splay beyond the dots. So.
Exactly.
Has a big shoulder, so.
As you can see how far out from
you can see the nice shoulder there. It's about 1 millimeter of shoulder, so.
Yeah, right. So that's kind of the idea why.
I think 6 is good.
So again, 12. Okay, down. Down. Okay, good. All right, so we're able to expand it nicely. And so now we're going to do a couple of DSA runs.
Yeah, the moment of the truth. So.
Well, hopefully, right? Vishal is not very good with the filter, so we got to watch it. As you can see, the filter is migrating down now.
I mean, what's happening is, Vishal is pulling, you're pushing. So in the process,
I don't know. Somehow when Haroon and I do it, it just never happens. So.
I have no comments.
We just let it go. After some time,
I would leave it to the choice.
After some time to the audience, you just got to let it go. Remember that Elsa and Anna said the
same thing. You know what they say, you have to take the repercussion of the choices you make. That's what it is.
You know, Elsa and Anna said the same thing.
Oh, my.
You're watching too much Frozen.
Yeah, well, Vishal has a beautiful 2 girls, and they both say the same thing to him. Let it go, Daddy.
That's a nice result.
Yeah, not the best flow, but, we'll figure out why. We'll figure out why in a second. Might have some issues going on proximally or distally. I hope not. We'll see. At this stage, there's no thrombus hang up that I see, but we'll see.
I think it looks very good.
Good flow. So this is a patient I would put on Xarelto, 2.5.
2.5 as part of the compass study.
I definitely, well, even more than that, just for, I guess, more for me than any study. I think that the flow is not the best. I definitely want to be able to, see, the ostium looks great. Everything looks really good. But, I just want to keep this flow going and then get him to stop smoking. Give me a filter retrieval device.
Take a picture of the outflow PK just so that the viewers
I'm going to capture the filter anyway. Let's get the filter out. So let's mag up on the filter, guys. Filter retrieval device. Give me some nitro or nipride, Liz.
So Vishal, just so that it's on record, for a change, PK was agreeable with our decision.
I actually, I don't know. I mean, the audience has been very clear. They've spoken. Vishal and you are not good with filters. And, it's life. I mean, listen, you have to deal with the cards you're dealt with, and, I'm dealt with cards.
What can I say? I can't say anything against my mentor, and Vishal has to keep his job, so exactly. We can't say anything about it. We both are
my
in a
God.
we both have different reasons to keep quiet.
Exactly.
So
We have our own decisions to make. So what are you gonna
You
do?
guys are funny. You know that? All right, good. All done. Out. Let's give me some nitride, please. Nitride. So we're gonna give 200 a nitride. All right, 100 then. Ooh.
PK, I keep getting emails here. Everybody's saying, "Oh, this is America, this is democracy," right? And I keep saying Sinai is like Russia, It's a dictatorship here, so
I
we have to listen to we have to listen to whatever PK says. So
remember, remember Putin is watching. So you know. Yep. Here's another 150 of nitro. Blood pressure drop, but he's okay.
It's fine.
Okay.
Fluids.
Wide open fluids, guys.
I'm sure if he's watching, he's proud of it. So
Yeah, really. Okay, so it's just under an hour. We were able to do this nice
I got
case.
48.
Right? It's going to be a nice case. We're going to shut her in here, reduce our radiation intake. Let's hopefully we don't have any surprises. Little die. We'll see how this thing looks.
I mean, the filter flow was good. The outflow.
You can see
the
right,
PSA shot here?
perfect. No, we just filled it and it looks very good right there. So we'll start from the foot and we'll come up. Wait for the blood pressure to come up a little bit
I think that's going to get
as
better.
Liz manages the blood pressure a little bit. Ready to inject?
Ready when you are.
Inject. So here's the 150 of nitride and the flow. There it comes somehow.
It's just the blood pressure is also on a low.
Blood pressure
Can you give
is low.
100 of Neo?
Neo.
Okay.
It'll come up. All right, give me a catheter, guys. We're going to go down below. It's exactly what we thought. Sometimes things happen. Give me a aqua tempo.
I just need a little bit of blood pressure.
Aqua tempo.
Yeah.
So likely nothing, but we'll figure it out.
Yeah, probably just go down with a catheter and give a lot of verapamil, nitro, vasodilators.
Mm-hmm.
Probably
his
just a
blood
lot of
pressure was on a
spasm.
lower. Yeah, the blood
Yeah.
pressure was also on a lower side in the 60s and 70s.
Just
I
give
think
a little
that's
bit of neo and then vasodilators.
Yeah, I think the
This is
Neo.
a straight one, but I guess it's okay. All right, let's see. Show me above, guys.
Yeah.
So again, don't get alarmed when you see this. This is common, a lot of microembolization, and so we're just going to go in now with the catheter, hopefully right into the stent, and then we'll decide. Need a wire probably.
Give me a wire. Any wire.
Yep, need a wire.
Oh, it's okay.
Yep, I see it. Give me just a 035 Willie. Yep. Mm-hmm.
PK, you're just testing out how good the stent strength is that it?
Yeah, really, right? So here goes the Willie all the way down, and then we're just going to take this down to the edge of the stent, and then we're going to probably give some more verapamil now. Oh, heart rate's kind of low, so no
Blood pressure
verapamil.
is better. We'll try.
Blood pressure is a little better.
I mean, you can always give neo, so it's okay.
So we'll take a shot here.
So PK, just now that we have this, Vishal, you tell me. So I know we are giving vasodilators and seeing if the vasodilators doesn't improve the flow, what would you do, Vishal?
And then you have to really figure out where we're distally embolized, and then try to go down, try to selectively engage the tibials, whichever, AT or PT, and wire it and try to see if we can do a little bit of focus, a little bit balloon dilatation, or maybe aspiration because we already have the aspiration device open. So.
Okay. PK, what would you do?
Yeah.
It's microembolization.
Right, exactly.
Yeah.
So we get more verapamil, nitride,
Yeah.
neo. We just keep going neo, verapamil, nitride.
So what I'm going to do now is I'm just going to inject. Give me the nitride now. So what the best thing to do here is to just inject through the catheter, 200. Yeah. Now what I'll do is I'll inject through the catheter, and then what I'm going to do is I'm going to attach the now go ahead and flush now.
Flushing.
So under pressure, flush the whole thing down. Right, just keep flushing. So when you flush now, you have a lot of pressure going in. Just keep flushing.
PK, if it doesn't improve, would you individually go into every single vessel and try to give vasodilators?
I may go into the foot with an 014 catheter and then decide, right? What it looks like. But at this stage, I think just violent flushing and just lots of nitride is going to help. You know, I mean, this is the next step will be to do exactly what you said, is to keep doing that. Okay, let's see now.
Mm-hmm. Look at that.
Yeah, this is good. Looks like, no?
Yeah, it just.
I mean, it's just the same thing. Pressure has to come up a little bit.
It's just damp. Hold on.
That's okay. It's just.
Oh, we got
damp,
an
yeah.
Yeah.
Already getting better.
Yeah. Look at the microcirculation in the muscle.
Already getting better. So it's okay. Let's just look at that carefully, see what we see.
I mean, the tibial vessels are clean. I mean, there's just very mild disease and not many major.
I just want to make sure that we didn't lose anything here. So we're just going to go down again. Okay, inject.
Mm-hmm.
Yeah, I think we are good.
Yeah, I mean, it's just a lot of microembolization, but I think as the flow gets good with the Xarelto, everything.
And also, I think once the patient starts walking and everything, I think
more mobilization.
With mobilization, I think the calf muscles will take care of it.
So I guess in conclusion, I mean, first of all, I want to thank our AV crew, the guys in Medibox. They did a great job in being able to show the prior angio. We hadn't let them know about it, but thank you guys, thank you very much. And I think that honestly, overall this case really illustrated some of the decision-making processes. I mean, first from the crossing, to second is the use of atherectomy and filter, third to your decision in choosing your therapy of choice in this particular vessel, and also dealing with microembolization, which is going to occur despite what you think. Obviously, the handling of the filter by Dr. Kapoor left a lot to be desired, but we deal with it. You have to deal with it. But I want all of you at home to get good assistants or good lead operators so everything works out. But all kidding aside, we really hope to see all of you in the NYEVS. We hope to see all the fellows at the New York or the Mount Sinai Endovascular Fellows course. And we hope this case has been very demonstrative. Thanks, Damien. Thanks, Liz, and thanks to everybody. We're going to close up here. This patient has had an endarterectomy on the contralateral side, so we're just probably going to make it a manual compression, and then we'll take it from there. So thanks again, Karthik.
Thank you.
Thank you. Thank you, Dr. Krishna and Dr. Kapoor. Fantastic case. Just want to wrap up by reiterating that, especially for people who have been attending our conference every year for the past 6 years for the endovascular conference, there is a change in the date and the month. Usually it's always in June. I just want to reiterate what PK said. It's going to be in April. The fellows course is going to be on April 29th for all the fellows, because they have to register it, they have to plan for it. And then I think the main conference is going to be on April 30th and May 1st, as PK said. And it's going to be on a different location. It's a great time of the month for New York City. I think it's in the middle of spring and summer, so it's actually great. So it's we look forward to seeing you guys, and please do email us with questions if you have, and we would love to answer your questions. Thank you for supporting us and joining us. Have a great day.